today. We're going to cover a little bit on variants and in particular their impact on vaccines. And the end of the talk, I'll kind of give some updates on vaccine booster. I put the date there as of today because as of last night, there were 3 more studies that were published just in the New England Journal of Medicine regarding boosters. And so I did update that toward the end of my slide, but as with anything COVID, this is only as updated as the current hour. And so things could change. As we know, tomorrow there is going to be a meeting among FDA, the vaccine group, to discuss boosters in the US, particularly among the Pfizer vaccine at this time. So we'll see what they have to review. So my objectives for today are to, again, review those COVID-2 variants that are currently of concern in both the US as well as across the globe. I'm going to highlight mostly Delta, as well as a little bit on the Mu variant, because that's been picking up a little bit of interest in the media, and we'll talk about whether we need to be concerned with that right now. And then we'll look at how these variants are impacting our treatment and vaccines. And then again, I'll talk about those boosters. So first, for those that weren't on my variant talk, I guess about a year ago or so, how do we define a variant? And it is when we have a strain that has at least 1 or more mutations, typically, that change it from that original wild type strain, or whatever was the predominant strain in that region. In SARS-CoV-2 variants, we've actually been seeing them even since January of 2020 or December of 2019 within Wuhan. They had more than 1 variant so quickly after the onset of that virus being detected. And so it's not unusual or uncommon with SARS-CoV-2. And it's actually common among all RNA viruses. And so SARS-CoV-2 is one of our RNA viruses. We think about influenza, which is why we alter the flu vaccine each year. We think about HIV. We can get mutations among our HIV viruses, particularly that can impact our ability to treat our patients. And the mutations occur because of errors that are made during replication of that virus. And sometimes in the majority of these variants, they actually have no importance on changing how that virus behaves or acts. But occasionally a mutation will be made that will help it evade immune response or increase its resistance to therapeutics or increase the infectivity or transmissibility of that virus. And so of the mutations that lead to one of those last 3 that gives that virus then what's called a fitness advantage, that's the ones that we have to be concerned with both in clinical practice and public health, because it impacts then the contagiousness of that strain or the protection that we can offer. And so there's 2 different categories of variants right now. There's variants of interest, which means we see mutations that are there that we need further study for. They look like they could be a problem, but we don't yet have the data showing that they are. And then there's variants of concern, which means they've already demonstrated a change of significance for global public health. And this is from the WHO definitions. And so that means they either have noted or proven increased transmissibility or a detrimental change in the epidemiology of the current COVID-19. They have an increase in virulence or a change in how they clinically present. Or we see a decreased effectiveness with our public health or social distancing measures, the use of our current diagnostics, or the therapeutics of our current vaccines or treatments. And so one of those categories has to be met for it to be labeled as a variant of concern. So with the WHO, again, I mentioned they've been tracking variants since the very beginning, and they currently have 4 variants of concern listed, the most recent being Delta, which was in May of 2021 when it first got that designation. The variants of interest are another 5 different variants. And again, the most recent one for that one is this variant called Mu, which was labeled that as of August 30th, so only 2 weeks ago. Within the US, we're a little bit similar. So these were the variants of concern in the US as of September 6th. And as you can see, I have the date on my slide. And we can see the names there. So Alpha, or the UK strain, was the one that we were very concerned with back in last spring or into June. Beta was a South African that really never took off here in the US too much. And then Delta has certainly become predominant. And it's become so predominant that when I went online today just to see if they've made any changes to the variants of concern in the US, they've actually now only listing Delta as their variant of concern in the US. And they have actually removed those other 3 from their descriptive page of variants of concern. Variants of interest in the US remain 4 of the same that are with WHO, but we have not yet labeled the Mu variant as a variant of interest yet in the US. And the reason for that is here. And so if we look at this slide, this is updated every Tuesday evening through the CDC. And what it is a breakdown of each week of what the sequencing or the genotypic sequencing of variants in our country are showing. And so back in June, we had some Alpha or UK variant with the beginning of the Delta variant. As you can see, the last several weeks, it's all Delta. And in fact, if we look at the percentages, the Delta is 99.5 or 99.6 of our variants identified here in the US. The Mu variant is only 0.1%. And so again, it's not yet one that we have listed as a variant of interest for the US. And just going to show you, the prior 3 variants of concern are no longer listed as that because they're just not prevalent, or even there's not any cases being recognized of them right now. Now, the hallmark to that is not every single person infected has a sequence of their strain, but it is the collection of the community. And so Delta is currently the only one in the US that we are seeing and that we're concerned with. So if we look at the Delta variant mutations, this is not a full list of them. It has over 15 different mutations, but some that have been identified to have impact. The D950, which is this orange little location that is in the center of this spike protein, it allows for increased transmissibility is what it's been proven to do. Whereas the green mutations seen here, which are located on the super site, the antigenic super site, allow for avoidance of immune detection. And so that's 2 different ways that it's changing how this strain interacts in our communities. The L452 and the T478, so the blue and yellow, as you can see here, they're actually on the receptor binding domains of this spike protein, and it increases really affinity to binding to our ACE2 receptors in our cells. And so it kind of helps that linkage, which is required for that virus then to enter our cells. And so that's how it's helped it in terms of survival or fitness, is by increasing that binding or that affinity. So then what do we know? If it's able to have increased transmissibility, we've seen it in clinical situations where it causes twice as many infections given the ability to spread. And so among an unvaccinated person with the original COVID strain, typically outside of a super spreader event, you would infect 2 others, was the R naught, if you would. Among the Delta variant, though, among an unvaccinated, it's up to 5 different individuals, again, in a non-super spreader event. And so it's labeled now as more than 2 times as contagious as the original strain. And then there's this question of increased severity of illness. This has been a little bit difficult to truly assess because we now have vaccines. And so we are seeing certainly more infections in a younger population than we did previously. But also we know that the older population has been vaccinated more often. And so yes, there is probably an increase in severity among certain populations, but if you compare different countries or different even states among vaccine status, you might see differences in hospitalizations and severity of disease. This is looking at cases across the US from way back in August 2020, more than a year ago, to now. And so this is hospitalizations. And so we haven't reached the peak across the US as we did back last winter, where it was 14,000, 15,000 cases compared to 12,000 hospitalizations now. But that's because you're including in that US-wide some states that have really great vaccination rates with low hospitalizations right now. If we look at our own state, we've surpassed our peak from last winter. Despite having vaccinations, we know we're not a state that has high vaccination rates, and we can see that with our numbers. We are at the highest level, this is as of yesterday, highest level of hospitalizations, highest level of those in ICUs, the highest level of those on ventilators. And that is impacting all of our hospitals, I believe, across our state. And so we would argue with our Delta variant in West Virginia that it does look like there's more severity of disease. The caveat there is we don't have high vaccination rates. And so it may have been different if we had a higher portion of our state vaccinated. So what is the data on actual immune evasion? So I talked about those mutations that suggest it can evade immunity. This was a study pre-published right now, just a week ago, on looking at patients who had prior infection with COVID-19 in early 2020. So this is that question I get a lot of times from people, well, what about natural immunity? And so first of all, small study, only 12 people. And they tested their their serum, so you have antibodies from that prior infection, and they tested it against both the original wild type COVID as well as the Alpha or the UK strain, as well as the South African and the Delta. And what you can see with the Delta, which is the one we're concerned with right now, there was a 5.7-fold decrease in its ability to neutralize virus compared to the wild type. And so, yes, there is some antibody response there from a prior infection, but it's not as protective as you might think. But what about if I've been vaccinated? Do I have protection? And so this was, again, small study from the same group looking at 10 people who got the AstraZeneca, which is a similar vaccine platform to the J&J, versus those who got the Pfizer vaccine. And the Pfizer vaccine is on the right. So that's one of the mRNA vaccines. And they looked again at wild type, the Alpha UK strain, and the Delta strain. And what you can see is that in both groups, whether using the AstraZeneca versus the Pfizer, there was a 9 or an 8.4 fold reduction. So about an 8-fold reduction in the ability to neutralize virus in those who had been vaccinated. Now, the caveat here, yes, they were all fully vaccinated, did not necessarily give details as to how recent that vaccination was. So this was a larger study looking at the exact same thing. So I'm looking at AstraZeneca and Pfizer. I now have about 60 people, 30 in each arm. The median age of those in this group were 67 and 71, so a little older of a cohort. And I did actually report then, well, how recent was their second dose? We know that you want it to be at least 14 days from your second dose to have that highest point of immune response, but how far out were they? And on average, nearly 4 weeks, so 31 days versus 27 days, so similar in both groups. And what they found was that the GMT titer, which is your antibody or your antibody response that can neutralize virus, significantly dropped compared to wild type. And so even against the wild type 30 days out from your second dose, you had a pretty high immune response there. So 7,393 was the Pfizer group compared to 2,625 in the AstraZeneca. But when they used it against the Delta, you had a significant drop off. And in fact, in the mean there, nearly half of the drop off there. And so that was concerning. It was a 2.9% fold decrease among the Delta variant for Pfizer. But that's just looking at your neutralization ability. That doesn't necessarily correlate with severity of disease and hospitalizations, which I'll show going forward. This was another smaller study looking again at convalescent serum. Again, that question of, well, what if I've already been infected? Am I still protected? And the reason why I'm showing this one in addition to the one I showed prior was, please note, only 24 people, but note that there were several individuals who had no detectable antibody response or neutralizing activity. They fall below that cutoff line. So not only do we see reduction across the board, but we saw some people with a prior infection who had no neutralizing antibody response. And so that would be a bit concerning. This serum was tested 1 to 3 months after their initial infection. So 31 to 91 days from onset. So that idea that I was infected just 2 months ago, I'm protected, may not map out to be the same because everyone's immune response, depending on the severity of infection they had, is quite different, which is why our recommendation for those is to still be vaccinated. And then lastly, another small study looking at Moderna and Pfizer, so both of the mRNAs. Again, 15 in the Moderna group and 10 in the Pfizer group, which is down at the bottom, Moderna at the top. You did see a 3-fold reduction. This is the Delta variant. This is the Japan-Brazil variant that we did not see here in the US as much, but this is the Delta variant here. As you see, a 3-fold drop with Moderna and a similar 3.3-fold drop with Pfizer. Small numbers, only 10 and 15, but do note that all of those who have been vaccinated still had neutralizing activity detected. So they weren't below 0 or below detection like we saw with those who had had a prior infection. So that's a key difference there. These are small numbers, and so I want to get into vaccine efficacy after I talk about the new variant, but it was a trend that we saw was that, yes, neutralization activity is decreased against the Delta variant, regardless of which vaccine you got or regardless of whether you'd had a prior infection. So what about this new variant? So it was first isolated in Colombia back in January. It's actually been detected now in a little over 40 countries. It's been present in all 40, or not all, in 49 of 50 states to date, including in West Virginia. And this is based on the sequencing data that is reported. And it includes, again, more than 5 different mutations, particularly more than 5 mutations in its spike protein. I just want to highlight some of those mutations are ones we've seen before. So that D950N, which we saw in the Delta strain, is that increased transmissibility factor. We can see that there is similar ones to what we've seen with the beta and the gamma strains or with the alpha strain. And so the concern and why the WHO has listed it as a variant of interest right now is because some of its mutations look similar to others that became variants of concern. So is there increased transmissibility, and is there an increased evasion of immunity? So data is too early to make conclusions. One would argue right now that it doesn't seem to have increased transmissibility from what we can tell, and that it hasn't shown dominance yet in any country except for when it first came out in Colombia in January. If it's present in all 49 or in 49 states in the US, it's still only making up 0.1% of the variants in the US, with Delta predominating. So one would argue that if it was more easily transmissible, we should see its percentage rise, and it hasn't budged from 0.1 in the last 4 weeks. So again, not yet one of interest in the US. If you look at the ability of it to evade their therapeutics, so we think about Regen-CoV, which is the SARS-CoV-2 monoclonal antibodies we use for early treatment, there was no change with Delta, and it's shown down here too with all these blue areas. And then Colombia, the red arrow, is the mu variant. And again, there was no change in susceptibility to this monoclonal antibody. So at least on that side of things, our therapeutics are still effective. What about in comparison of those who had a prior infection and now getting exposed to the mu variant? So this was, again, another convalescent serum study where they took only 8 people. So again, very small numbers. They took 8 people who had been infected with COVID over a year ago, so April to September 2020. And they then ran their serum, which has those antibodies in it from that prior infection, against all the different variants that are interest or concern right now through the WHO. And as you can see with the mu variant, there was a higher reduction in its ability to neutralize compared to even with Delta here in the orange, which was a 4 times reduction. It was 12.4 reduction with the mu variant. So that's a bit concerning to think about, but only 8 specimens. If you look at those who have been vaccinated, so that's the second thing, those with the Pfizer vaccine, they had 10 different individuals that they tested. Again, we saw a reduction, a 7.6-fold reduction compared to the wild type or the original strain. The Delta, again, was only 2.6 in this study, and so significantly a larger reduction as compared to our current Delta strain. And so again, that's a reason why there's interest there, but only 10 specimens, and I'm gonna say this again before I move into vaccine efficacy. Reduction and neutralization and vaccine efficacy are not equal. And so what I don't want is the myth to continue to go out there that the vaccines are no longer effective. And how do we know that? Well, we're going to talk about the vaccine efficacy now. So if I look at vaccine efficacy, meaning how does it protect me from infection, or how does it also protect me from hospitalizations? We need to look at some of the larger studies that have been done. And so this was out of the UK, and they compared both their Alpha UK strain to the Delta strain when Delta was popular there last spring. And they used what's called a test negative case control. And that means their controls were not just random individuals. Their controls were people who presented with COVID-like symptoms, but tested negative. And so that was to try and get rid of any bias that might happen on your controls. And so of those that tested for Delta, there was 4,272. And of those that tested for Alpha, there was 14,837. And what they did among those was they looked at their vaccination status as compared to those negative controls who presented with COVID-like symptoms but tested negative. And what they found, if they looked at, it doesn't matter which vaccine you got, if you had gotten a single dose of either vaccine, you had a 48.7% vaccine efficacy against infection with Delta, with only a 30.7 efficacy against Delta. But when you looked at having received 2 doses already, so being fully vaccinated, we saw that the vaccine efficacy against Delta was 79.6, and for Alpha, it was 87.5. So still a significantly a protective note even against Delta. And this was, again, whether or not you got AstraZeneca or the Pfizer vaccine. When they further broke it down between the 2 different vaccines, they actually found that the Pfizer vaccine had an 88% efficacy against infection with Delta. So this is not just hospitalization or severe disease, but testing positive, versus 67% with the AstraZeneca vaccine. So certainly superior as compared to the AstraZeneca vaccine, but both highly effective at that point, if we think about some of our other vaccine efficacy that we use. What about in the US? There's a lot of data on here. I'm going to just highlight what I want you to really pay attention to. But just for reference, this was from January to June. So that's something to remember, because from January to June, we did not have a lot of Delta. We didn't start really getting Delta until June, and certainly didn't take off until the July and August weeks. But this looked at people presenting to either the hospital and being hospitalized, or presenting to an ER or urgent care, again, with COVID-like symptoms. And so they were tested for COVID. And this was not I'm coming in with a broken leg, but I'm getting screened for COVID because I'm gonna be admitted. This was people who had symptoms of a COVID-like illness. And what they compared were, among those who had been vaccinated with Pfizer or Moderna or the J&J vaccine, they looked at what was the positive percent for a SARS-CoV-2 infection versus those that were unvaccinated. And you can see among the unvaccinated for hospitalization, it was 18.1% positivity among those presenting with symptoms like COVID. Whereas in those who were fully vaccinated with Pfizer, it was 1.9%. So a significant reduction seen there. With Moderna, it was 1.5% positivity. And then with J&J, the total number was a little bit lower, just because not all 7 healthcare systems had used the J&J vaccine. So the total number was a little bit reduced, but it was 18.6% among unvaccinated versus 4.2% among the vaccinated. So again, this was showing protection against infection, not just against those who were hospitalized or those who presented to the ER. Again, this was before Delta was prominent though, so that would be the one hallmark to see here. In this same study, I'm not going to go through the details here, it did look at also older age groups, so 50 versus over age 85. It also looked at those with chronic conditions, as well as at different ethnicities. And again, it still showed across all of those different breakdown of groups, if you had been fully vaccinated versus unvaccinated, there was a protection or efficacy that was seen to be still quite high over here in these ranges above 75%. So what about other studies that have been published or have been at least released so far? So the Public Health England, they released a study that was looking from April through June. And so that was when Delta started to take off in the UK. And they found that there was a 96% effective against hospitalization with Pfizer, 88% effective against symptomatic disease with those who are fully vaccinated against Pfizer. So not just severity or hospitalization, but symptomatic disease. 92% effective against hospitalization with the AstraZeneca vaccine. And of the Delta variant, there was over 14,000 cases that resulted in 166 hospitalizations. And so again, still efficacious against symptomatic disease in that initial study. In Canada, there was a separate study that was done last December through May. And so this is going to contain a bulk of patients who were having the UK variant, and then towards the end, having some of that Delta variant. And they looked at symptomatic COVID positive individuals versus those COVID negative tests. But again, among controls who presented with symptoms like COVID, trying to match those people up. And they found that for Pfizer group, after full vaccination, so they were more than 2 weeks from their second dose, 87% protection against symptomatic disease. And with Moderna, it was 72% against symptomatic disease with 1 dose. They actually didn't have any cases identified in those that had been fully vaccinated with both doses, but they cautioned in their study that Moderna was introduced late into their population, so they didn't really have a whole lot of numbers with Moderna. In another study out of Scotland that was looked at from April to June, they looked at confirmed COVID infections, and they did note that of the 19,543 infections they looked at, over 7,000 were Delta variants. So it was, a good chunk of their study was among Delta patients. For Pfizer fully vaccinated 14 days after their second dose, they had a 79% effective against a Delta infection. So not symptomatic disease, not hospitalizations, against Delta infection. And then with the AstraZeneca, it was 60% effective against Delta infection. So again, still showing that these vaccines are quite efficacious for protection from the Delta variant. And then the Israeli study, and I'm going to go into more details on its booster aspect, but this should be bolded now because it has been published just as of yesterday. But they looked at among their fully vaccinated with Pfizer, they saw overall a 64% effective against the Delta infection in terms of those who had received vaccination. If they broke down to say, well, when did you get vaccination? Looking at those who got vaccinated early back in January, February 2021, they did note that there was a higher breakthrough infection rate and a lower efficacy seen, but not a drop in severe infection as compared to those who got vaccinated later. Again, I was waiting for the full report. Some of it has come out as of last night, but some questions that were asked from this study was, well, were these all symptomatic disease? Were they asymptomatic? Is there bias? Because if I'm someone who got vaccinated early in January, February, just like here, then I'm probably high risk. Either I'm a healthcare worker on the front line, or I'm an older individual, or I have an immunocompromised condition. And so there is a little bit of bias there to say, well, you got vaccinated early, you're going to have some waning of immunity, but you're also in that group who's at higher risk. And they also didn't comment on, at least in the preprint, well, of those who get vaccinated, there could be a bias to say, well, if you trust vaccines, you probably are going to trust the test. You're probably going to present for testing compared to those who maybe did not get vaccinated. And so there's some confounding there to consider. And then what about, this has been comparing those vaccinated versus unvaccinated. This study is a little bit different in that not only did it compare different vaccination groups, it compared those who had a prior infection with COVID. So this was out of Oxford University. And the difference here was that they randomly selected households to get SARS-CoV-2 PCR testing, regardless of any symptoms and regardless of their vaccination status. And this was across May through August. And so this is when Delta was taking off in the UK. And so among those with fully vaccinated Pfizer, it was 80% efficacious against SARS-CoV-2 Delta positivity on a PCR test. For AstraZeneca, it was 67% efficacious against having a positive test. But they did note that for every 30 days from their second dose, so the farther out you got from when you got your vaccine, they did see a reduction in that efficacy. What I want to point out with my arrow here is the time frame. If they looked at the Delta only from May through August, again, we saw with only one dose, 57 or 46% efficacious. After having a second dose, 82 and 71%. More than 14 days after your second dose, 80 and 67%. And this green column are those who were not vaccinated, but previously infected. And so you can see the protection there against the Delta was 72% among those with a prior infection. So it's still pretty good. Not as great as the vaccine though, but still pretty good in that group. Again, the limitation to this study, which hasn't been fully published yet, is that we don't know the timing of when they had their infection. And so that could also have an impact of that immune response. And then more recently, just a week ago from the MWR, it reported on COVID-19 vaccine effectiveness against ED and urgent care visits or hospitalizations. And this looked at 9 states. And they looked at adults who were 18 or older who were tested for SARS-CoV-2 either at the time of that visit or within the prior 2 weeks to 3 days after that visit. And they had to have had a diagnosis entered of a COVID-19-like illness. That's how they pulled these records. And again, that's trying to not have any outliers there who happen to be screened positive, but they actually weren't symptomatic and so forth. So if I looked at hospitalizations among the unvaccinated, 18.9% versus those that were fully vaccinated with any of the vaccines, only 3.1%. And then it broke it down. The Pfizer was 80% vaccine efficacy among hospitalized patients versus 95% for Moderna, although smaller numbers, and then 60% for J&J. And then the similar thing was seen with ED and urgent care visits. Again, 82% for any fully vaccinated individual compared to 77% if you broke it down to just Pfizer versus Moderna at 92%. So Moderna did seem to look a little bit better from this data, and there has been some reports that it may have a little bit better protection against Delta as compared to Pfizer, but we're still waiting on Moderna to share more of their actual individual data. So if anyone questions, and this is something that I've been sharing on social media platforms and so forth, as whether the vaccines work, I think this is a graph that probably people have seen, or one very similar to that, looking at the fully vaccinated rate of hospitalizations versus the unvaccinated rate. You can look at it in West Virginia as well. So this is the number of breakthrough cases of those who were vaccinated, so 8,000 cases, compared to 138,000 of those who were not vaccinated. And again, if we look at deaths, 94 deaths among those who are fully vaccinated compared to over 2,000 of those not fully vaccinated. And then I showed you the graph of the hospital numbers we have, but if we actually look at who's vaccinated and who's not, among all hospitalizations, 84% are among unvaccinated. Among those in the ICU, over 90% are unvaccinated. And among those on the ventilator, 91% and higher are those who are unvaccinated. So we should take from this that yes, the vaccines are protective. Yes, they work, certainly against hospitalization, severe disease. But yes, there is some drop in that immune titer or that immune response against that Delta variant to infection. And so what about boosters? This will be the last few slides I have to talk about. So vaccine boosters, I don't think anyone will disagree that they would increase your antibody titer or your immune response for at least a period of time. And the first group that vaccine boosters were looked at were among those who were immunocompromised. And so this was looking, this is a study that was done many months ago, looking at the percent of subjects who had an antibody response, detectable antibody response after having completed at least 2 mRNA COVID vaccine doses, whether it was Pfizer or Moderna. And this study did not delineate. And they looked at different conditions. So among patients with cancer, those with solid tumors, so solid organ cancers, did okay. They were still highly detectable, at least 80% or more. Among those with hematologic cancer, so we think about our bone marrow patients, people with leukemia, people with CLL, there was a significant drop in an antibody percent with antibody response after having 2 doses. If you look at those with dialysis, they actually did pretty well. So 60% or higher had a response. If you look at organ transplant, this was the group that had the huge drop off. And this is really what led to looking further into boosters, is that we can see that several, if not the majority of those who were solid organ transplant did not have response. And then of immunosuppressive therapy. So we know a lot of patients are on different immune modulating agents for either autoimmune diseases like rheumatoid arthritis or other such therapies. We can see that there is a reduction in response after being fully vaccinated. So then what happened if you gave a 3rd dose? So this was a randomized trial with Moderna alone among solid organ transplant patients, where 60 individuals received a 3rd dose and 57 received a placebo dose. And again, none of us would argue that you're not going to get some response with that 3rd dose. And you can see on the left column is actually getting a 3rd dose. On the right for all of these graphs is getting the placebo. That you can see their antibody titers, their neutralization percentage is much higher after that 3rd dose. In Pfizer, very similar, they looked at 101 solid organ transplant patients, and they gave a 3rd dose 2 months after completing their initial 2-shot series. And again, the prevalence of having any anti-SARS-CoV-2 antibodies before the 3rd dose in these 100 patients was 40% prevalence, and it increased to 71 months after that 3rd dose. So there was a response. Not everyone responded, but certainly a significant amount did increase. And this was showing the antibody titers, how high the titers went. So I don't think there's a question among those with immunocompromising conditions, and this is why it's already been approved for those individuals, that they should get a booster and they need a booster. But what about among immunocompetent, or those of us who do not have immunocompromising conditions? So this was just published last night, and this was actually published from a Pfizer-backed study, and so it was Pfizer's data themselves. And so 2 things to point out. Very small numbers. They looked at 11 participants and 12 participants in different age groups, ages 18 to 55 versus ages 65 to 85. And the reason why they looked at this was that another article that just got published last night in New England Journal of Medicine was following among that clinical trial where you had over 40,000 people in the Pfizer clinical trial, and again, over 20,000 of them who actually got vaccine compared to placebo. They actually shared the data of what happened beyond that 6 months. And what they found was showing that they did see a drop in vaccine efficacy, or a drop in that immune titer response, at about 6% drop every 2 months. And so after 4 months, instead of being at 95%, you were around 87 or so percent. And so because of that, they then looked to say, okay, well, what happens with a booster? And so what did we see among this 18 to 55? So technically, this is the group that is not at severe risk. They're not that 65 and older. And this is, again, potentially not among those who are immunocompromised, although they didn't spell it out in the trial. If we look at the green bars, that is against wild type. So this is what was your immune response or your neutralization activity against the wild type. And then they looked at beta here in this graph, and beta was a South African variant that we did not really see here in the US. But you can see that their titer increased against wild type by 5 times compared to the 1 month after dose 2 to the 1 month after dose 3. And for those with the beta response, it was 15 times among, again, that younger age population. Among the older group, again, only 12 participants, they saw a 7 times higher GMT among those who got the 3rd dose, 1 month after 3rd dose, compared to what their 1 month after dose 2 was. And similar with the beta response. And the timing of their 3rd dose, unlike the solid organ transplant where they got it after 2 months, they waited, on average, it was 7 to 9 months, so around 8 months after your 2nd dose to get that booster shot. Again, a total of only 23 people. But what about Delta? So they looked at those same people, and they then did a neutralization against the Delta variant. And so with the Delta, you saw a very similar response of a GMT neutralization titer increased 5 times compared to what the 1 month after dose 2, and 12 times in that older group. So that data supports, certainly boosters will increase our antibody titer for neutralization, but it would also help in activity against the Delta variant. But what does that mean in real world? So this is looking at serum in the lab, and it's looking to say, okay, do we see neutralization happening? But what does it do for actual real world data? And that's where the Israeli study came out. And this was, again, published just last night in the New England Journal of Medicine, although the preprint has been out for over a week. And so they looked at patients or people who were 60 or older. They'd all been fully vaccinated with Pfizer by the end of March. And so they had already gotten their 2 doses before the end of March of 2021. They made booster doses available starting on July 30th for those who are 60 and older and who had been vaccinated 5 months prior. And so that was their caveat. And so they looked at, among those who chose to get a booster, they followed them for 12 days after the booster dose to identify how many ended up getting an infection compared to those who did not take the booster. And so the reason why the numbers kind of change here is that this non-booster group, some of them moved over to the booster group after a few days, right? Because maybe on day 1, I didn't get my booster, but day 2, I got my booster shot. And so they found that there was 11.3 rate reduction in confirmed infections among those who got a booster compared to those who did not get a booster. And for severe illness, they also saw that drop, that 19.5 rate reduction in severe disease or severe illness compared to those who did not get a booster. And so this was more real world data instead of just being in the lab or looking at a titer response, that it was quite protective, and it was protective early within that first 12 days. And then they extended it and said, well, we followed out to 25 days. But as you can see, the more farther out we get, the confidence intervals get quite large. So there is some question there, but it did continue to show the factor reduction in confirmed infections, usually around 7 up to around 17 or 18 reduction in confirmed infections among those who got their booster vaccine. Now, they mentioned, and we need to consider, there was some caveats to this. So on the one hand, they're announcing they're doing boosters because they're having a spike in cases. And so that may change people's behavior. And so if I'm, again, back to someone who wants to get the vaccine or wants to take a booster, I probably might also maybe take more precautions in my interactions. I might also be wearing a mask, or I might also be doing some social distancing. So is it all from getting that booster shot, or is it because I changed some of my own strategies? And so that's something to remember when we look at the impact of boosters. And then I'm going to end my last slide and then open up to questions. This was published on Monday night in the Lancet, and this was among vaccine experts across the globe, talking about, do we really need boosters for everyone who's been vaccinated so far? And they broke it down looking at, so what is the vaccine efficacy against severe disease? So they did address it against severe disease. And they first looked at what, among all the reports that have been published to date, looking at vaccine efficacy against severe disease, we can see the cutoffs. So here is, I have a vaccine efficacy of 100%. This line is 90%. This line is 80%. We get to 70%. And they highlight the number of published studies so far, or at least reports so far, that still showed a 90% or higher vaccine efficacy against severe disease. There were 13 that showed at least between 80 and 90% efficacy against severe disease. And there were 26 reports that did show it drop below 80, but it's still higher than 50% efficacious. they looked at those same studies and said, well, what about on the different variants? So how many studies reported the different variants? And we can see there was 15 studies that have shown the impact of Delta variant and vaccine efficacy against severe disease. And again, that severity of that vaccine efficacy against any infection on this case was 80% versus severity of 80%. And then they looked at what type of vaccine. And so here in the US, we're using mostly the mRNA vaccines, and that's where the bulk of the studies were, over 32. And again, the average, the mean across those studies was still well over 90% against severe disease. If we bring in the vector vaccines, that's your J&J, your AstraZeneca, it did bring it down between 70 and 80%. And then their last slide was saying, or the last graph here was early versus later. So when I got infected, was my vaccination status more recent, or was my vaccination status later or more or later time ago? And so again, even in those who were vaccinated months prior, the vaccine efficacy against severe disease and against any infection was still quite protective. And so this was an argument that was made that, should we be recommending boosters for everyone who's been vaccinated 6 months or longer, given that we know that it's still quite protective against severe disease and hospitalizations. And then there's the current dilemma of vaccine equity. If we think about globally, I did a teleconference with Jamaica last night on COVID, and they're struggling just to have a single dose vaccine for the majority of their populations, even getting their first doses. And that's not from vaccine hesitancy, that's from supply. Whereas in places like here, the UK, Canada and Israel, where we're trying to give boosters to the general population, should we be doing that? Is there data that supports that? There's data that supports it does increase your antibody titers. There's one study so far from Israel that shows it improves testing positive or infection, but there's not any studies that show that it actually has a significant impact on severity of disease or hospitalizations as compared to the current 2-dose. So that's a debate. I guess we'll find out more after tomorrow's talk. So in my summary, so variant strains, they're expected in viruses, particularly in a pandemic situation, and we can expect more variants, particularly until we get control. The ongoing transmission that we have currently in the US and particularly in West Virginia, as well as across the globe, is going to lead to more variants developing because they just have such a population to keep spreading in. The Delta variant is the one that still remains of most concern. Its contagiousness and its evasion of immunity. The Mu variant is really too soon to tell for us. Please leave here knowing that vaccines are still effective and that get that message out to your patients and to the communities. And what's our response? Well, we should have mitigation effects. And so we should still be using our mask wearing. We should still be social distancing because that is certainly how we can protect ourselves from a breakthrough infection for those of us who are vaccinated. We need to get the rest of the population vaccinated, and that's something that we've been trying. And then, yes, there's going to be a question of a need for booster, but should it only be in certain populations or should it be in everyone? And that's kind of an ethical question that you have to ask. Not sure what I would say myself, because I'm torn between both, but that's something that we'll find out more as the FDA comments tomorrow, hopefully, on what their thoughts are. So I will stop now and open up for questions.
Thank you so much, Dr. Reese. As we all know, it's an ever-evolving situation, so I really appreciate you always gathering the most up-to-date information and presenting that to us as a group. We did have one question in the chat. Before we jump into that, I see a couple of our other hub members are on as well, Dr. Costello and Dr. Weiss. So I didn't know if either of you wanted to comment on anything before we jump into the questions.
I have a comment and a question for Dr. Reese. So Becky, if you could put up, I don't know what number it was, but it was the Oxford University study with the table.
Yeah. Let me pull that up. Slideshow. Oh.
I'm going to say it was 12 from the end. That's it right there. Okay. So one of the things that's a little frustrating to me, and I can tell you this story, but it's too long to go into or whatever, but is that I think that what our goal would be an immune population, right? Just sort of this analogy to that is like when you think about measles, right? So when somebody comes in and they want to be a doctor or a nurse or a volunteer, like, oh, are you immune to measles? like, oh yeah, here's my shot record, or, oh yeah, I had measles when I was a kid, here's my titer, right? Oh, you're immune, good, right? And you know, and that's not a great analogy with COVID for a number of reasons, which I won't go into, but it's still there. So when you look at this, to the far right, the green, not vaccinated, but previously positive, and you look at the middle, which says VECT less than 30, which means that there was a lot of virus, this was a real infection and so on. And you go to the Delta, the second one, and so it says that the efficacy is on the average of 77%, which compares favorably or sort of right on with sort of the rest of the vaccinated group. Now, you can look at, as Dr. Reese did, and look at titers and how fast do the titers wane against whatever we're measuring. But one of the things that you have to remember is that if you get the vaccine, you are getting, you're getting the antigen that's in the vaccine, right? And we can test for that. When you get infected, we are making antibodies against, I'm making this number up, 1,000 different antigens that the virus has, right? And we don't know which of these viruses are the best markers of protection against subsequent disease and so on and so forth. So I look at this slide that you have, Becky, and I just like, that's pretty darn good for people who've been previously infected. And so I hear a lot of, I mean, I get, you know, emails and texts from any number of people. I hear from people on the phone and whatever. And they're like, I don't understand why, like in DC, some of my colleagues are like, they won't even let us get tested. I had Guillain-Barré with a flu shot. I don't want to get the vaccine. I've had COVID. My titers are high and they're still saying I have to get vaccinated. Why? And that's my question is like, yeah, I don't know why. Because what we should be concerning ourselves with, are we immune? And so that's all I'll say about that. And Becky, if you want to respond, if you don't want to, that's fine too.
Yeah, I mean, I have two thoughts on that. I completely agree. I think if we had a way to truly check for people's immunity with our testing, and I don't think we have that yet. You know, I don't think we can trust all of our IgG, spike protein, antibody titer response. If we had that, then yeah, I think that would be reasonable to consider testing that if someone reports they've had a positive test. I don't want to take their word for it because again, people don't want to get vaccinated right now. So if I had that, I would say yes. The second question I guess is I have is that it's so different among individual people. So personally speaking, on the hospital side, I have seen more people who had a prior infection that I can see they're positive SARS-CoV-2 from 6 months ago or 8 months ago get admitted with COVID compared to those who have been vaccinated. And so now that's me being biased by what I see in the hospital. And again, it won't appeal to the whole general population, but I would use it if we had a good titer test that would catch those who had prior infection, you know, like for measles, I can certainly see, like we've got a test, we know what it's going to show. I can say that, but some people who had a prior infection, if I check the current spike RB protein that we're looking at, they don't show a response. And so then I don't have proof that you have immunity.
Okay, thanks, Becky.
Mm-hmm.
Awesome. Thank you so much. We'll get into the question that we got from Carrie in the chat here. So she said, this is a little off topic for today, but I wonder if there's a concern for monoclonal antibody availability, given the very narrow timeline for effective use and the anticipated introduction of the state and distribution. So I'll open that up, Dr. Rees or anyone who wanted to chime in and answer that.
Yeah, I mean, I think that's certainly a great question. You know, we struggled when we looked at the use of a monoclonal antibody. We changed our guidance recently because of the availability to use it in prophylaxis now. And our question is, well, what happens when our supply gets low? Do we still offer it in those prophylaxis cases, or should we only be using it in treatment cases? at least at WVU, what we're looking at is now getting the sotrovimab, the other monoclonal antibody that shows that it's been standing up to some of those variant strains, looking to see, well, can we get that? What's the supply chain of that? Knowing that the REGEN-COV supply chain is becoming a little bit limited. But I agree, it's going to be, at some point, we're going to have to either narrow our use or not allow it to be used for post-exposure and only use it for treatment, even though it might be better in post-exposure group than treatment. But I don't know if Lisa has anything to say about that from the state level.
Sorry, I was going to chime in on that too. I think I lost my connection, but I think people may have seen this week that now the federal government is taking over monoclonal antibodies. So you are right, in West Virginia, you know, we certainly have seen a bigger demand than we have supply coming into the state. And there is a big push by the pandemic leadership and the governor to want to make sure that we're able to provide that, particularly in more rural areas. So with the federal government pharmacies now being able to distribute and administer the monoclonal antibodies. So I do think and share Dr. Reese's concern that I think we have to be looking at what patients we're going to be using them on. But there certainly is a concern in regards to the demand outpacing the supply right now, particularly as we're seeing such a high caseload in West Virginia and in other states. Some of it is repositioning. So sometimes we have monoclonal, but just not in the place that it needs to be. But, there also is, as we've seen at least this last week, there's just more a demand for it than what we've been given from the federal supply. Now, I will say our federal allocation is based upon how much we use our prior week supply. So ensuring that we do use the doses that are provided to us is going to be important in regards to future federal allocations.
Thank you so much, Dr. Costello. No other questions in the chat so far. I don't know if anyone else wanted to maybe unmute and chime in if they had a question, or if there are any other comments from the Hub team. We got a question in the chat from Samantha. Thank you so much. She said, my patients are dealing with major anxieties and are often afraid to leave their homes. What may be a reasonable response that will reduce anxiety and encourage vigilance at the same time? That's a great question. Thank you, Samantha.
Sorry, I guess my one question, so they're having anxiety about just leaving their home at all. My two questions for them are, one, are they vaccinated or have they been infected before? Do they have any type of immunity? And two, we do know that we know how it's transmitted. We know that there is a risk with airborne transmission, particularly in those close encounters. So mask wearing has been shown. There is plenty of evidence there that mask wearing is protective. Personally, I recommend for myself, if I'm going to be in a store or a close kind of area, I did go out and purchase through Amazon KN95s, just to be a little bit more protected currently with this with the Delta variant. But a double layered mask is going to be protective. I think the downside of trying to protect yourself by staying in your home is that it leads to isolation and leads to anxiety. It leads to depression, and I think we can all speak to having experienced that in the last year or longer now. Outdoor activities right now, the weather's still pretty good. There is less risk in the outdoor area, and trying to find that, or finding your hub of people who are vaccinated or at least protected and aren't taking risk is another good thing to consider.
Thank you, Dr. Reese. Dr. Weiss, Costello, were there any other comments you wanted to add to that? No worries if not.
Not for me, thank you.
No, I think the only other thing I would add is what I learned from a recent national PEDS. Is there another reason for their anxiety? Is it someone lost a job or they've had a death in the family member? So I think in pediatrics, we're looking at the space of, yes, COVID is certainly a cause of it, but are there other reasons contributing to that anxiety that is, to Dr. Reese's point, why are they anxious? And if it's solely for COVID, or is there another underlying, issue that can then also be addressed? So this is something that certainly I know in PEDS we're looking at, in regards to, is it, certainly COVID is going to play a role, but many a times there may be another contributing factor leading to that anxiety and depression as well.
That's a great point. Thank you so much. And Dr. Bixler was kind enough to add a resource in the chat, reduced risk of reinfection with COVID vaccine. So I'll make sure that's in the recap email as well. Thank you. Any other questions or comments from the group? We do have a few minutes left here and we do have the poll, but I don't want to end the session early if we don't have to. Alrighty, well, if there are any questions after the fact, as always, you're more than welcome to email either myself or Elizabeth. We're more than happy to help answer questions. And Dr. Reese, we really appreciate you presenting today. So thank you very much for that. And I want to just thank each and every one of you for joining the session too. This wouldn't be possible without you all. So I just want to shout out all of you guys here today. I will go ahead and launch the poll. Again, it's not mandatory, but the feedback is very helpful for us. So if you'd like to fill that out, we would really appreciate it. Let me go ahead and post that. The only announcement that I have is that our next session will be on October 21st from 12:15 to 1:15. Once we get more information on presenters and topics and things like that, we'll be sure to let you all know. So thank you. And anytime you finish the poll, just feel free to exit the meeting. Thank you guys.